Pierre, a fellow here at the Swedish Neuroscience Institute. And for our neurosurgery grand rounds, I'd like to introduce, it is the honor and pleasure for me to introduce Dr. Rod Oskouian. Dr. Rod Oskouian, he completed his neurosurgery residency training program under the tutelage of Dr. John Jane Sr. And then from there, he was able to proceed to come down to Seattle, where he now serves as the chief of spine surgery here within the department of the Swedish Neuroscience Institute. For all those who know Dr. Oskouian, he is an innovator, a very strong-minded individual who always thinks about the future. And the one way he applies this to patients is he's able to implement not only the scientific technological advances, but he's able to incorporate it in individualized patient care. He's an accomplished researcher. He's published many scientific journals as well as medical textbooks. He helps spearhead and direct the collaborative efforts here with the team of Seattle Science Foundation, which has been instrumental in making a change by connecting physicians as well as researchers all around the world with this online platform. One of the things I admire most about my mentor, Dr. Oskouian, is that he uses every opportunity as a teachable moment, whether it's in the operating room, in the clinic, or even at a restaurant with his catch-all phrase, "Wow, isn't this amazing?" He's a loving family man. He has a wife and 3 beautiful daughters. And it is my pleasure to introduce to you Dr. Oskouian.
Thank you so much, Cliff. It's really an honor for me to be here this morning. And, I think it's amazing to me. I've been here for 15 years, and when I look back over the last 15 years, especially over the last few years, there's been some crazy things that have happened. Who would have thought that we'd have a pandemic and a lot of, things happening in healthcare. There's just a lot of dynamic shifts that are taking place. And I think, when I reflect back on 15 years, I look at, kind of what's happened, especially right now. I think if you look in, just in general, like with the stock market being up and down, physician burnout rates very high, healthcare systems are losing a lot of money. The insurance companies, pharma, device companies are having record profits. And to me, whenever you see these big dynamic shifts happening, I kind of look at it as an opportunity. And you kind of have to reevaluate what you're doing and what things, as physicians, how do we do things in such a way to make it sustainable? And I think for me, this talk really is, if you look at somebody like John Jane, who, if you look at medicine, science, business, and, for example, even music, you see people that have really changed the game. And when you look at John Jane, I think, he's just an amazing person. I was very fortunate to have him in my life and as a mentor. And what I've come to realize as I get older is it's all about having high functioning teams and creating a culture and people around you that that's the key to success. That's what John Jane did, and he created this culture. We trained in this small little town in Charlottesville, but he had this legacy, and he was there for 40 years as the chairman, produced numerous chairmen all over the country, all over the world. But he created this culture, and he had a very small team. Again, I mean, what I learned from him, he just had an insatiable appetite for learning. He read a lot. He traveled a lot. And even through tough times like we're going through now in medicine, he learned really to kind of be innovative and to create. And I always will remember this about him is, he always when you have your losses, he was like, you got to grieve, regroup, and think about what you want to do. But he really was a pioneer. And when I look at, people like John Jane, it's an inspiration. And even during COVID, I spent a lot of time reading something which I felt like I kind of put away just because we get so busy, with our schedules. And here's some great pictures of John Jane in his office with my family. And here's some more great pictures of him with his family and some of his good friends. And again, if you look in science, you look at someone like Einstein, people give him a lot of credit for a lot of great things he's done. But what people don't understand is Einstein had a great team, okay? Even all these, for example, take the theory of relativity. This was one of his grad students, and he had a very small team, but it was a very high-functioning team. And that was the key to his success. And when I look at, my career, and when I look at a place like the Seattle Science Foundation here, there's a high-functioning team here. And when I came here, there was nothing. This was an old building that had been bought and remodeled, and there was no activity up at SSF. It was a beautiful facility. It had all this infrastructure. You can see all the, capabilities in terms of, being plugged in, but there was no team. And the team here now, there's like 7 full-time employees. It's incredible. And some are actually here now. Alexis Takasumi, Linda Celine, Angela Tran, Ben Rupp, Gary Hawley, this, and Corey Kepler. It's a very small team, but it's a super high functioning team. And again, being in medicine, I always felt like our societies failed us, right? They all have their own interests. They put on all these meetings, cost thousands of dollars. You have to travel. And when you go, they don't even record anything. And you go to the meeting, and then it's you can't listen to talks, you can't. So again, having the influence of John Jane and kind of thinking outside the box, I was like, there's got to be a better way to do this. And so when we started working here at SSF, we were like, okay, how are we going to change this, and how are we going to change education? And to me, it was pretty simple. You have to have a high functioning team and really good docs. And that's kind of what that was the mission from day one, was to create this platform that was centered around education, but you had to have those 2 components.
So what makes
this is a pretty cool video, but you can see, like, even a small video like that, it gets your attention, right? It's a physician, he's talking, he's on, the technology, the platform. And if you just look at the numbers, which we do every now and then, and Alexis put this talk together for me and put these numbers in, it's absolutely mind-boggling to me that if you look, this is 7 people created this. And I can tell you, not one single society has more views than Seattle Science Foundation. And here's one of our former fellows who now is in training in Mississippi, and it's working with really talented young people like Cliff, and the rest of the people that come here, and they're the ones that develop the content. They're very passionate, and the team here at SSF is really dedicated to making this platform for the physicians. And, if you look, for example, and people always ask me, yeah, we do a lot of spine talks and everything, but really it's all specialties. Everyone has access to SSF. You can be a cardiologist, you can be a thoracic surgeon, you can be a cardiac surgeon. It's wide open. And we've had our doors open to all physicians from all institutions all over the country. And over the last 15 years, this is the network that we've developed. We have probably one of the most powerful networks in the world. And these are all the major institutions that we work with and we partner with, and it's mutually beneficial. So the physicians love it because they can have the platform to do what they want. They can talk about what they're passionate about. And the team here at SSF is really dedicated to the doctors because they know that that's what's going to drive, the program. And this is just, one example of like a journal club. You can see all the docs on there. They're in the OR, they're in their office, they're at soccer practice, and they're tuning in because, that's what docs do. They love, being able to connect. And I kind of view SSF as the global connector. And it's because there's trusted content on there, right? So when I go on there and look at stuff, I'm like, wow, I can't believe this. Dr. Beal from Oklahoma is giving a talk on kyphoplasty. Great, I'll go by and check it out. And another thing that SSF has done, which has been really creative and innovative, is they've developed these CME programs, which again, it's too bad, but our societies have failed at doing it. It's very difficult for the hospitals to do it. And, that between ACCME, industry, and physicians, it's challenging to develop, these courses because a lot of times there's budget constraints, there's facility constraints, and, kudos to SSF for, getting these courses online. And this is mind-boggling to me. There's 18 million views now, and it's like Moore's law, in technology it becomes exponential, right? So if it's 18 million this year, next year it's gonna be 36. The amount, once you hit a certain point, it just starts to grow exponentially. And during COVID, we couldn't even get people to download Zoom. No one even knew about Teams. We had all this technology, right? But we just didn't use it, and it wasn't part of our normal everyday lifestyle. But since COVID happened, it's even gone up higher. And because we had all that content, we were using this technology, it's even made it more popular with physicians, and even patients go on. For example, this is a video that was done in the lab. And I'm going to show you another video which was shot in the OR. And again, this is done with one or two people from SSF going down and watching a surgery, and then having a couple people at SSF put a video together. But this video has gotten 41 million views. And it's online. You can easily see it. Imagine if you're a Parkinson's patient and you're going to go have a deep brain stimulator placed. I can guarantee you probably have watched this video. And it's
My name is Ryder Gwynn. I'm a neurosurgeon here at Swedish Neuroscience Institute. And today I'd like to talk about a surgical case where we're performing deep.
And so, it's stuff like this that I think for me,
I want to thank
this is another video that I did. I was supposed to go to Argentina, but I couldn't go. And the team here at SSF, I was able to do it from the lab. And, and in South America, traditionally everyone travels, and I couldn't because of various reasons, my schedule. And I've gotten so many people watch it. It's unbelievable to me. And again, if you look at business, for example, look at Ray Dalio. He's the most successful hedge fund manager in the world. And people think he's the smartest guy in the world. But he's like, I'm really not. But I have a great team, and he has a very high functioning team. And he's got a couple great books, and I encourage you to read them. But he always talks about, the team being transparent, having realistic goals, and, having a mindset where, like, for example, in investing, his motto is like, okay, don't invest the way everybody else does. Do something that's a little different. And that's why he's been successful. And again, I kind of use SSF as an example, but, they're able to be the global connector because they're doing things differently, right? They're not doing what everyone else does. They're not trying to, repeat what, for example, our societies do, where, they charge you an exorbitant amount of membership and then you go to the meeting, and it's all industry trying to sell you stuff, right? And I think again, when you look at it and you see what's available, like this is a course they did here at SSF, and all these docs
I'm very
came
glad that you
from all
organized
over the
this
world.
with SSF, Shuttle Science Foundation, Harborview Medical Center, and of course with our sponsor, Stryker. It's very helpful for us in terms of teaching us how to do.
And again, this is an example of like, it's working with industry and then trying to promote education, but then at the same time, you're helping docs from all over the world advance. For example, this was a course on trauma and fracture care. Well, what's the most common thing that people see in third world countries? Well, it's trauma. It's basic things like leg fractures, arm fractures, hip fractures. So, and working with industry, they were able to put this course on with a organization called Sign. Again, it was very innovative, and they recorded all the stuff. It's online. You can go check it out. And then the other thing we've done with the team here is develop like a journal club. This is one example of a journal club that was done with University of Maryland, where, again, it was just done for like an hour. It was at night. We recorded everything. Look at all the countries that people, logged on and looked at the videos, and it didn't really, it wasn't a huge investment in terms of, like resources, but look how much traction one journal club got. And again, this is a great team here at SSF. This is what, here's some great pictures of our fellows and what the place looks like when there's a lab. But we always try to record everything and put it online and have it available for the physicians so they can access it. Again, when I look at SSF, and what I kind of was getting really frustrated with is our societies, even whenever I would go to a meeting, I was like, okay, well, if you look at neurosurgery, we have even two societies. And okay, which society do I go to? And then within those societies, there's like spine, cranial, there's CV. And so when we were here in Seattle, I said, look, why don't we think about doing something that's a little different? Why don't we have it focused on, for example, not necessarily the society or industry, but let's focus on the physicians, because they're the ones that are going to, change the game. And instead of, trying to change the societies, which I knew would never happen, right? I can't go and change. Those societies are going to do what they're going to do. Why not think about doing something innovative? And even when you look, for example, I love spine surgery. That's my passion. That's what I do. When you look at research and innovation, which is something most docs are heavily invested in, the traditional way of writing a grant, getting money from the federal government, NIH, having a lab, and then having the institution take overhead, and then you publish in some obscure journal that someone has to get a subscription to. I mean, to me, those are old paradigms, and they're not functional anymore. People, it's not sustainable. And so when you look at, for example, here on this campus and at SSF, we've tried to change the game in research and innovation. And, how can you solve clinical problems and make it relevant, make it so that, let's say if you've got for example, I'm a spine surgeon, here are the things that I deal with, and what are ways that I can improve patient care? Well, doing it the old way, I think, isn't going to work. So you kind of have to think outside the box. So this is like a regular week here at SSF, and you can see there's almost every day there's something going on. And what I've learned is just even coming up here and, for example, talking to the plastic surgeon that's in the lab that's doing something, I've learned a lot. I've learned about, how to manage wounds. And I learned the most from the fellows. The fellows up here, we've had some great research projects. And I think for me, you have to think about like these things like research, innovation, and you can do some very cool things if you think outside the box and have a high functioning team. And this is what we've done here at the Seattle Science Foundation. For example, we use this app called Trello. The fellows put all their projects on there. You can see who's doing what. And then when they leave, there's a to-do list, and the next team comes on. It's like a handoff, and it's, I think using technology is also important, which again, typically when you have a research program, it's like, okay, if someone leaves, that information is lost forever, and you're never going to get it back. And these are some examples of fellows that we've had, Bazem, Ishak, Emra. I mean, they're all surgeons now in their respective countries. They're leaders in their field. And there's a great picture of our fellows. We had a journal club. And again, we had fun. We ordered pizza. It was a collaborative night. And we had thousands of people, view our presentations and our work. And it's a very different way to kind of think about it. Usually, most journal clubs are kind of stale. You kind of go over it. No one records anything, and it's spontaneous. So, like during that meeting, there were some funny things that happened, and it was all recorded. Nobody edited, and that's kind of fun, right? And again, these different things that we've done, they've created other programs and have inspired other research projects. And for me, again, just kind of going back to what I was talking about earlier, if you look in other industries, and one person that I kind of see, like, here's Rick Rubin, okay? Who's Rick Rubin? Nobody really knows, right? But this guy is the most successful music producer of all time. He discovered hip hop. He reinvented Johnny Cash. I mean, the guy is legendary. And it's not that he's, he's a very smart guy, but guess what? He's got a high functioning team, and it's not a lot of people. And he's written several books. He's got a really good one that's come out now, but it's, change how you think normally things can be done and view it differently. There's a great quote that he has in his book, and I think the take-home message is just going through this experience, whatever it is, even if you fail, it becomes a learning experience for you, and you go, okay, this is very cool. And so that's, I think for me, it's an important part of, as a physician, like 9 out of 10 times I'm going to fail at doing whatever I'm going to do, but you take those 9 out of 10 times and you learn from it, and it makes you smarter. And you can't look at failure as being not successful. In fact, my father used to say, what determines how successful you are in life is how you bounce back from your failures, not all the successes you have, right? I mean, if you were successful all the time, then when you do fail, it's going to be catastrophic. So I'm going to change subjects now, and I'm going to talk about some innovative procedures and talk about what I love doing, which is spine surgery. And again, using this whole concept of like thinking different, thinking outside the box, and how do you, with the platform and the team here, how do you innovate? How do you change the game in spine surgery? That's kind of what I'm passionate about. And again, I'm very fortunate. We have a very high functioning spine service. When I first came here, it was just me. Throughout the years, we've recruited some superstar all-star surgeons. Jens Chapman was one of them, and he loves doing complex reconstructions. And when he came, we were doing these horrific cases, and they would take all day. Okay, we'd be there for like 12, 13 hours. patients would lose 2, 3, 4 liters of blood. We would do what's called a pedicle subtraction osteotomy, was basically in a vertebral column resection where you take an entire vertebral body out, and then you can manipulate the spine however you want. And Jens is, in my mind, probably one of the greatest spine surgeons internationally and in the world. And we both worked together, and we got, okay, there's got to be a better way to do this. And, there's got to be a better way to do these spine deformities. And with our high-functioning team here at SSF, the fellows, and industry, we worked together and basically came up with a new procedure, and it's called the intradiscal osteotomy. And Jerry Robinson promises to write this up, and I know Abe is working on our clinical results, but we've probably done this in now 300-400 patients. And it's taking everything that you know about spine surgery and flipping it around and using old techniques and procedures and really being able to correct the spine in any direction you want. And historically, again, we'd have to take the vertebral body in order to manipulate the spine. Jens, for a long time, was doing this through the disc space, but we just didn't have the instrumentation and the hardware. And in fact, this technique goes back almost to the 50s, but it evolved and evolved by doing some lab work here, courses, talking to other physicians, being in that, like I was saying earlier, like in that, global community where we have present cases. And so we started doing this. We started doing it clinically and also at the same time in the lab where, you go in, you basically would take off all the posterior elements, which you normally do in spine anyways. But instead of going through the vertebral body, which was very bloody, we'd go through the disc space. And then again, as the techniques evolved, technologies evolved, we can do this faster, quicker. The devices have gotten better. The techniques have gotten better. And you can literally correct the spine in any direction you want. And here's some cases that we've done. And you can see the amount of correction you can get just by doing what's called an intradiscal osteotomy. Here's a great example of, here's someone who's had previous surgery. Again, if in the old days, you'd have to do, PSO, VCR, tons of blood loss, patient be in the hospital forever. Here, we did a 1-level IDO. The patient went home 4 days later. Here's another case where a patient had a chin-on-chest deformity. Historically, this would be non-operable. You couldn't do anything. And then here we did a 3-column IDO, got her head nice and straight. And this is a life-changing procedure for this patient. And again, we took a procedure that we'd done in the past and kind of just flipped it around. And, this patient did great. And we've been following her. Here's another revision case where a patient kind of collapsed in between, and we're able to do this reconstruction. And again, all these little things that we did, and over time, it's all the additive effects, right? So if you look and see what we did, and all these people, Ray Dalio, Rick Rubin, Einstein, it's just you keep picking away at what you're doing. Eventually, you'll get over the hump, and that's kind of what I've tried to do in my career. And I do a lot of spine surgery, and so I've always tried to push the envelope. I'm like, is there a better way to do spine surgery? And for me, as you guys all know, I love doing minimally invasive spine surgery. The fellows on my service right now, Jimmy and Mauricio, were laughing because I told them, I said, we're going to do all MIS surgery for the next 6 months. And they didn't think I could do MIS surgery, but we're doing all this MIS surgery. And for me, historically, MIS surgery, people always go, oh, you can operate through like a little tube. And then there's always like if you look on these magazines, there'd be like a model with a Band-Aid on their back. And they're like, my back pain is gone. That was like what people said MIS surgery is. But I always looked at it and I said, well, is that really MIS surgery? That patient maybe didn't even need surgery in the first place, right? So MIS surgery for me is how can you change the game in terms of what you did in the past and make it better? And when I first got done with residency, there's this crazy Brazilian neurosurgeon who was doing these procedures, and he was kind of a wild guy, and Brazilians are like that anyways. And South America is just its own planet. And I remember actually the meeting was in Seattle, and he was talking about doing, through an endoscope, all this stuff through the abdomen, and this evolved. And I was very fortunate. And again, SSF had a lot to do with this, is that it put me in this space where I was like, okay, I was young in my career. I was trying to figure out how to do stuff. And this evolved into doing lateral surgery. And at the time, there was no codes. There was a little company that was just being started, and it was a retractor company. They had no devices, no implants, there was no neuromonitoring. But I was like, oh, maybe there's something to this. And so I started really going down this pathway of like, maybe there's a better way to do spine surgery, and kind of thinking outside the box. But then there was this new procedure. It was kind of crazy. It was a little scary. You were going in this area that people normally don't go. And so for me, it was kind of this odyssey in terms of like, I kind of thought it was cool, but then I didn't feel like the procedures that were being done were quite there in terms of trying to be able to do the procedure. And here's some of my disclosures for this. I am conflicted a little bit. But when I look at, for example, when you do minimally invasive surgery, or if you do lateral surgery, basically in my world is how do you get to the spine with minimal disruption? That's kind of how I look at it. Doesn't matter if it's through a tube or if it's through a retractor, and if you can get to the spine and do the work, that's kind of what matters. And so that was what's so important to me about doing lateral surgery, is looking at getting the spine in a different way. And this is what I did here at SSF, is I used the cadaver lab a lot because this was anatomy as a neurosurgeon I wasn't taught, okay? So urologists will usually work in the retroperitoneal space. That's not a space that we feel comfortable with. This is a great anatomical description of where you work when you're doing lateral surgery. There's the psoas, there's the kidney. These are structures that are retroperitoneal, right? Usually we're not taught this. So understanding, I had to fully understand what that anatomy was. I wasn't trained in med school. All the textbooks that we have on the lumbar plexus are all wrong. That's not how it is in real life. This is a nice cadaver dissection. Here's some more dissections of, our fellows in the lab, and coloring, and Cliff did many of these himself, where, we went in and mapped out the plexus. And what we realized is that, when we're doing this, and when I was doing this procedure, most of the textbook in medicine, you look at Gray's Anatomy, you look at all the anatomical books that we're trained on, they're hundreds of years old. No one ever questions and says, okay, Gray's Anatomy is wrong. You just can't do that in medicine. And a lot of the diagrams, they get passed on and they're repeated. And so like, here's an example of the lumbar plexus diagram. That's not what it really looks like in real life. It's like the brachial plexus. People draw it because you can memorize it, like, the cords, the trunks, but in real life, this is not what the plexus looks like. The real life, it looks like this. It's embedded in the psoas, and it's not in any of the textbooks that I've read. And this is actually very cool 3D reconstruction using MRI images, CT scan, that one of our fellows, Perry, did, where we mapped out the plexus. And this is the first time this has ever been done. And what's very interesting to me is that when you look at the lumbar plexus, and if you just look at males and females, it's also different. And then, so it's like every person, although the general anatomy, like where the femoral nerve goes over L4-5, where the obturator nerve goes, I mean, these are more or less very similar, but each person is very different. And we've done cadaver studies with our research here, and we've been able to show, yeah, there's some differences, but each patient actually has a very unique lumbar plexus. So when you're doing lateral surgery, you have to map it out. And this is I really like this picture because it shows you a couple things, is that it's very complicated. And then even if you look at, for example, this is a great picture I like to show. This is Jens Chapman and his cousin, right? They look very similar, but I can guarantee you they have, their lumbar plexus is going to be a little bit different. But if you look at their facial features, Jens and his cousin look very similar. So their plexus is probably going to be similar. And if you get an MRI of someone and then you try it, and then you go to the OR, it's going to be completely different because, first of all, in MRIs, you really only see the psoas. So you have to map this out. And this is a great flora shot, and these are guide wires going in. You can see the subcostal nerve, ilioinguinal nerve, general femoral. And again, this is what the plexus looks like when you look at it in a cadaver with these sheaths going through. And this is what it looks like. It goes through the psoas, and you really can't see it. So when you're doing lateral surgery, you have to map it out. Otherwise, you can have patients have femoral nerve palsies and all sorts of complications. And when I first started doing lateral surgery, it's very interesting because when I would do it, I would use a microscope and I would go down, I would go through every layer of the psoas muscle and I would find the femoral nerve, and then I would use a metrics tube and then dock anterior to it. And it's incredible to me in the last 15 years, how far we've come. And again, if you look at the old textbooks, the plexus is rarely mentioned. This is a great, diagram. But, most of what we've learned in the last 15 years, and especially in spine surgery, is, this is all new, these are all new procedures that were not historically done. And here's another great, this is a real CT reconstruction of, this is how complicated the nervous system and the lumbar plexus is. You can see all these nerves. You can see the femoral nerve, the obturator nerve, the general femoral nerve. You can't cut any of these nerves when you're doing lateral surgery. Each one is a functional nerve. And this looks, for me, this is super scary because look at all the nerves that are, if you're gonna go try to do this, this is extremely difficult to access the disc space when all these nerves are going by. So you have to understand the anatomy and how that works. And we started doing this work in the lab, and this is a great view. You can see the plexus, you can see how it's embedded on this, the lateral aspect of the spine. And this is after the psoas muscle's been cut out. So when we do lateral surgery, the orange is the disc space at L3-4 and the green is L4-5. You can see, for example, what we learned, the most difficult area to do lateral surgery is L4-5 because the femoral nerve goes right past the disc space, and you can see that. And that's almost universal, right? That relationship. But like I said earlier, each patient is different. So there might be a case where the femoral nerve goes right in the middle. There might be one that goes posterior. There might be but in general, it's kind of, 50-yard line for L4-5, which is the trickiest area to get to when you're doing lateral surgery. And again, a lot of the work was done here. It was done in the lab. And this is the first 3D reconstruction of a lumbar plexus. In fact, we published it. It's never been done, and it was very innovative. And Perry worked on this project and was done with a 3D reconstruction with taking actual MRI images, CT images, and reconstructing this. And this is what it looks like. When I look at this, it's kind of scary. I'm like, wow, you know, why are we even doing lateral if the nerves are right there? But it turns out you can do this, and you can do it in such a way that you can map out these nerves. And what I've learned just in the last 15 years is, you know, you really have to study the preoperative imaging. We use CT scans, MRIs. You can actually, you know, really get a good idea of what it's going to be. And again, for me, the more difficult cases to do lateral surgery are patients that are very thin, osteoporotic. You know, you just know they're going to have, you know, issues with doing this procedure. For me, the real game changer of spine surgery has been all this new technology that we never had. So, and what I've tried to do is apply these principles that I learned to other pathologies. So I started doing this in the lumbar spine, but then I had these really horrific cases that we get here at Swedish. For example, this is a patient that I got that had a calcified thoracic disc, and the patient had 7 back surgeries. First, they did her lumbar spine, and then they did her thoracic disc 3 or 4 times. Her brother was actually an orthopedic surgeon, and they came here from Colorado. And this is another cool example, put another plug in for the Seattle Science Foundation. They watched my videos online, and he called me, and he said, look, my sister has this problem. She's had multiple surgeries from the back. She's getting worse. She has this calcified disc. And he said, is there a way that you could do this from a lateral approach? And I was like, you know, I've never thought about doing it in the chest. That's a great idea. And so I did a couple lateral approaches in the lab. And then I said, you know, and she'd already had multiple laminectomies. And the last time they opened her up, and then on the table, she was starting to lose her signals. So they just closed back up and said, we're not doing anything. And then, so I said, well, you know, and the family came up, and I said, look, this is a high-risk procedure, but she was getting worse. I mean, she was in a wheelchair by the time I saw her. And I said, look, you know, I haven't done this before in thoracic spine. It's very risky. I don't know if it's going to work out, but I do think we can potentially help you. And this is what we ended up doing. So I did a lateral procedure. And again, instead of, you know, trying to put an inner body cage in, I said, well, is there a way that I could drill all the way, take the back wall off and have the cord herniate? Instead of it going backwards, can I have the cord kind of move more anterior and not even try to go after the calcified disc, which was there? And that's what we did, and we actually were able to do it. And again, we had to go through the chest, and you can see the retractor there. We were able to go all the way across the vertebral body, and under the operating microscope, you could actually see the dura. And typically, when we do these in the thoracic spine, you point towards the cord, and you do it like you would like a normal open procedure. You drill off the rib head, you find the neural frame, and you go back. And again, this is a combination of kind of my theme is, you know, you take an old procedure, which is a thoracic disc, and you challenge yourself, and you say, is there a way that we can do this better? Because the risks of going posterior are so high. And again, she woke up weak. It took her probably a good 6 months, but she's walking now. And every year I get a card and a fruit basket from this family. And it's incredible to me, you know, that you could, in something like this where, you know, this to me, I think is truly a game-changing procedure, but it's using a different paradigm to treat the same problems that we deal with all the time. And after I started doing these cases, I was like, well, gosh, you know, maybe there's a way to treat, address trauma. You know, here's, for example, a patient who had initially looked like a benign fracture in someone who was osteoporotic, and then was, I think we braced her, we did everything we could, and then this is what ended up happening. And she actually came back to the ER, was essentially paraplegic. And one of the other issues that I faced during my career is having an access surgeon. So, she comes in, I think she came in like most of these patients do, it was like midnight, right? And how do you get hold of the vascular surgeon, the thoracic surgeon? We work here at Cherry Hill, so it's hard to coordinate that. By the time if I get all these people, it'll be, lunchtime, maybe in the afternoon the next day. Well, if you're doing lateral surgery or a new approach, which I was doing at the time, maybe you can tackle this by just doing a lateral approach and be able to get this fracture out. And actually, we did. We were able to do this. We got the patient to the OR relatively quickly. And again, because she's older, I wanted to try to do the least amount to try to give her the best chance for recovery. And this is what we ended up doing. Again, in my career, this patient would have had a much bigger surgery if we didn't have access to this. And, probably would have had surgery the next day, but it would have just taken a lot longer. The incision would have been bigger. There'd been a lot more blood loss. But it certainly, I think it made me more resilient in the terms of like saying, okay, you can treat new pathologies with a new procedure. But again, because of the fact that you have to coordinate all these things, it sometimes makes it challenging to do these cases. Here's another case, in fact, that was done, and this is more elective, but here's someone who had a fusion, had failure, and then I went in, took out all the hardware, took out the did a vertebrectomy, and then staged it. And then I started applying, so we were like, okay, we can do this in trauma, burst fractures. What about doing it in tumor cases? And, no one had really been doing corpectomies in the lumbar spine because of the plexus. So we started doing it in cancer patients and had good results, was able to get a very large inner body and take out and do it safely, right? So these patients would, and for cancer patients, it was a game changer. These patients would go home, a day or two after surgery. And again, but through this, I think through my experience as a spine surgeon, it's, you have to do those extremely difficult, painful cases where, you lose tons of blood. You go, okay, there's got to be a better way that we can do this. And then going back to my theme earlier about, using, for example, when you look in science and medicine, you look at John Jane, Rick Rubin, the music producer I talked about earlier, and then Ray Dalio. Ray Dalio has a great quote, and I think this is true for me. It's like you have to endure pain, right? And then you have to go through these things in your life, but it's also important to reflect and say, okay, well, maybe doing the old way, which is this is the old way, right? Is doing you can see this is a open procedure for doing a corpectomy, which is what I used to do when I first started doing. Maybe there's a better way to do this, but you have to go through this. You have to do one of these extremely difficult, painful cases to get to this, because you won't understand, and you have to reflect and say, okay, like, is there a better way to do it? Maybe there's not. But nowadays we can do these cases, we can do it through a minimally invasive approach. And as Jimmy and Mauricio have found out, there's always newer, better ways to do stuff. And hopefully, we can even do better than this. Here's a patient that I did recently that had an L3 metastatic lesion. Again, has had radiation, and chemotherapy and is always, and most cancer patients are, very leery of having more surgery, being in the hospital. And we did this procedure, and it's incredible to me. And 15 years ago, I thought we would never be able to do this, but we did this, and this patient had a 1-level vertebrectomy, and then we did a posterior fusion, and the patient went home the next day. I mean, this is incredible to me that you could do this. Again, 15 years ago, this patient would have been in the hospital probably for 10 days. And you can see the reconstruction that was done. And we used a small retractor, and we did the instrumentation was done percutaneously. And for cancer patients, this sort of procedure is a game changer. Here's another patient that I recently operated on that had a single, and she's like 15 years out from breast cancer, single metastatic lesion. And same thing again, we did this minimally invasively, went in, took out the vertebral body. This patient went home 3 days later. This is for this patient, a game changer. And most cancer patients are living longer and longer and longer. Like this patient, she's 15 years out. She's every 5 years had her 5-year anniversary of being cancer-free. And boom, she has one lesion pop up, and all her PET scans, SPECT scans were all negative. Again, you can so I've done 1-level corpectomies, and then I've even done 2-level corpectomies through a little tube. And the devices have now gotten so good. These devices now expand, so you can start with something very small, and then because of the engineering, 3D printing, all the technologies, I can put in a 3-level, 4-level cage through a minimally invasive approach. And this is another cancer patient. And again, this is what we were able to do for this patient. And here's another patient that had recent surgery. This is L4. Most people would say, okay, you can't do L4 because of the femoral nerve. You'll have a high rate of femoral nerve palsy. And I would say 10 years ago, yeah, I would agree. And I probably wouldn't do a corpectomy. But here we did an L4 corpectomy, and we're able to do it safely with minimal blood loss. A lot of these patients get embolized before surgery, and that helps a lot. But you can see here, we're able to put a very nice, did a very good reconstruction. And even now, as I continue to do these cases, I'm like, there's gotta be a better way to do it. And I'm always stimulated. We have such great fellows here. They're always pushing the envelope. They're always asking questions, and we did a case recently where this patient had another L3 lesion, and she had pretty big, her bone quality was not great, and then she had big, she'd had some procedures, but her iliac crests were gone because they had taken bone graft for another procedure she had. So we really didn't have good fixation, and she'd had so much radiation, and she was very thin. So I was a little bit worried about doing a lateral on her, and she'd had multiple abdominal surgeries. So I was like, is there a way we could potentially do this all posteriorly? And you can see her iliac crest, and this is what we ended up doing for this patient. You can see these are the MRIs. We actually did this all posteriorly from the back. So so it was one incision. And again, the technology's evolved. So we can put in now, most of the pedicle screws are fenestrated. So you can put cement in, so you get immediate fixation. Her bone quality was terrible. So I put in a pedicle screw, and you can see the cement in there. And then because of these newer devices, I was able to do a bilateral, far lateral vertebrectomy. And then we were able to sneak the cage in between the nerve roots and put it in and reconstruct the spine. And literally, we could do, we could correct this in whatever plane we wanted. This, again, I think this is an example of, kind of pushing the envelope a little bit. But for this patient, she's several years out. Unfortunately, she had other lesions come up, but this patient had several years of good, was pain-free and had this tiny little operation. And we were able to do all this through a tiny, small little incision. And something, again, even 10, 15 years ago, I would tell you that, wouldn't be possible. And we're able to do it. And here's another case, again, another example of an L4 lesion that we did. We went in laterally and then put in posterior instrumentation. Here's another cancer case we've done. And actually, I think one of the fellows from last year is collecting all the data. We've probably done more L3 and O4 corpectomies than anyone in the world. And here's another example of doing L4. And again, this patient went home several days later. And these are what the x-rays look like in my clinic. And you can see the nice, these implants they cover the end plates. So they provide a lot of structural support. You don't have to do, T10 of pelvis on someone like this. They can have 1 or 2 levels done and do very well. Here's one more case example of another cancer patient. Again, you can see in here we've put the percutaneous fenestrated screws first, and then I try to take out the back wall and then go in and take out the rest of the vertebral body. And you can see how big of a space you can create. And this is like an incision that's maybe 5 or 6 centimeters. And the fellows have done this with me. Literally, the incision goes from here to there, and then you're just opening up. It's a transverse incision. But you can see how much access you can get to the spine by doing this. And this is the size of the implant that you can put in. And all the companies now provide these various options. It doesn't matter, and again, this is an example of like technology, 3D printing. We have the ability to measure everything before surgery. We can do Hounsfield units for the spine, which is way more accurate than bone density. And then even now cements and evolved, the mixtures are better. They're easier to work with. They provide immediate fixation. And to me, it's only going to get better and better as the technology and our ability to like manufacture these products get better. And even now, what's cool is that they're developing, especially for cancer patients, like carbon fiber, things that, that have less radiation problems, like, artifact and imaging and things like that. And again, using the same approach, we've also done a lot of revision cases. So this is a very cool revision case that we did a couple of years ago. This is a patient who'd had a vertebrectomy, and you can see here it didn't heal. And then her hardware was starting to pull out. And actually, she'd had a big surgery from the front, but then had the small construct from the back. And we were able to go in, and because she had the shark bite incision, we were able to go laterally, and then we cut the cage, and you can see the photos there. That's the cage cut, and we put in a new implant, and she's done great. And again, I think each one of these cases present unique challenges, and I think for me, being able to, have the ability to do this lateral, I think really helped me, because traditionally, you'd have to go back in, either do posterior or do an anterior reconstruction. And the other amazing thing that I've been able to be a part of is having, all this knowledge and publishing all this information and just putting everything out there and working with the fellows and having access to the lab here at SSF. And we were able to, basically put all our work and put together a lot of different projects. One very cool project that I'm very proud of is, we kind of put this together and we're able to publish a book on this, and it's called The Surgical Anatomy of the Lumbar Plexus. And again, it's never been done, and a lot of the work that was done here at SSF is actually in this book. And I think, for me, being able to work here at Swedish, work at this foundation, working with the fellows, this is not me, this is the team, and having a great team and having this culture up here, and having access to all this is really cool. And I know we're short on time, but going back to what I was saying earlier, there's so many crazy things going on right now in if you look in the news. But I really think that I'm very optimistic about the future. We've done some great things in the last 15 years. I think it's wide open, and I really can't, predict the future, but I think, when you look at spine surgery, you look at what the folks are doing in endovascular surgery, brain tumors, medicine, technology, it's really a great time to be a doctor. And I think, as far as patient care, it's awesome. And I think, we're going to figure this out, and we're going to do it together. And I'm super excited about what the future holds. And thank you so much for inviting me to talk.
Hey, Rod,
Great.
are we doing questions? No questions. I think you're done.